Prevention of unrecognized abdominopelvic accidental puncture and laceration. My name is Dr. Clark Gerhart. I'm the Medical Director of Robotics and Minimally Invasive Surgery at Wilkes-Barre General Hospital. This is a community health systems hospital located in Wilkes-Barre, Pennsylvania. I practice robotic, general, and bariatric surgery, and by way of disclosure, I do receive honorariums for educational activities. This presentation has been made by the Surgery Advisory Council, which is an interdisciplinary subcommittee of the Community Health Systems Patient Safety Organization. It has been convened in the effort to identify common causes for lacerations and punctures in abdominopelvic surgical procedures in order to provide evidence-based best practices and to recommend preventative strategies. The content of this presentation is protected from disclosure pursuant to the Patient Safety and Quality Improvement Act. Unauthorized disclosure or duplication is prohibited. Accidental puncture and laceration of abdominal pelvic organs presents a serious safety event. Primarily, it produces poor patient outcomes. Enterotomies and vascular injuries result in a high rate of admission to the intensive care unit, also a higher rate of parenteral nutrition requirements, and longer overall hospital stay. They also increase complications and mortality for patients. It is also not uncommon. In a review done in 2008, Medicare has determined that this occurs in 2.83 out of 1,000 patients and is now one of Medicare's hospital value-based safety indicators. And while they are not uncommon, accidental punctures and lacerations are felt to be avoidable. The Centers for Medicare and Medicaid Services determined that they would not pay for the additional costs incurred by these complications because they were expected to be avoided. It also represents a high source of liability. The surgical error accounts for 12.3% of all medical malpractice claims, and the average claim costs $245,000 per incident. We will be focusing on safe entry into the abdomen during laparoscopic procedures because this procedure represents a significant risk for visceral and vascular injury. To accomplish safe entry into the abdomen, we will use the STAR method. We'll first begin by stopping and taking a moment to think about our options for entry. We will then think about the best location and method for entry, considering the patient's body mass index, previous surgery, and their present disease condition. We will then act by following the appropriate techniques and guidelines, which we will outline here. And then we will review. We will review how our entry has occurred safely, inspecting the abdomen for any sign of injury, and do ongoing review using this as a quality indicator. To accomplish safe entry, we will first choose a safe site of entry, then choose a safe method of entry, and finally we will complete a final inspection of the abdomen to ensure that no injury has occurred. Let's begin with choosing a safe site for entry into the abdomen. Certainly the umbilicus is the most commonly used site for entry into the abdominal cavity. In some instances where this is not most advantageous, there are alternate sites of entry, and we will discuss these here. Beginning with the umbilicus, we can see that the umbilical skin most closely approximates the underlying tissues and the peritoneal cavity. When using the umbilicus, the entry only has to traverse the skin, fascia, and peritoneum. So when entering here, there is relatively short distance and few structures before entering the peritoneal space. In alternate locations off of the umbilicus, there will be more layers to traverse, including the skin, subcutaneous tissue, Scarpa's fascia, the muscle fascia, and the peritoneum. So additional care must be taken to traverse all of these layers. In a virgin abdomen, certainly the umbilicus is a safe and reliable place to enter the abdomen. With prior subcostal incisions such as those used for hepatobiliary operations, there is the likelihood of adhesions. These adhesions will occur mostly in the right upper quadrant, however, and are typically well away from the umbilicus, so the umbilical area can still be an acceptable source of initial entry. Fan and steel operations used for low pelvic procedures likewise will cause relatively few adhesions, and those adhesions will be centered typically well away from the umbilicus, so the umbilicus can still be used in these locations, understanding that care should be taken to be alert for the presence of adhesions in the area of the umbilicus should they occur. Other sites of prior surgery that are away from the umbilicus include a McBurney's right lower quadrant incision, commonly used for appendectomies, and colostomies, which are typically off the midline through the rectus muscles. These also are away from the umbilicus, so in some cases the umbilicus can still be used safely, since adhesions will typically be away from the umbilical midline. However, given the prior disease states, involvement with infection and inflammation, there may be more extensive adhesions that impinge on the umbilicus, making entry more difficult. When using the umbilicus with off midline incisions, care must be taken, assuming the possibility of adhesions, and if entry is not obtained easily after 2 tries, then alternate sites should be chosen. In the case of an upper midline incision, even if it does not directly involve the umbilical skin, the surgeon should assume that there are periumbilical adhesions, since these incisions generally involve surrounding inflammation and will include much of the upper midline. In a similar way, a patient with a scar from a prior low midline incision should also be assumed to have scar tissue and adhesions covering the lower abdomen, and most likely including the area around the umbilicus. And without a doubt, long midline incisions that actually traverse the periumbilical region will typically cover the center of the abdomen with adhesions, and the umbilical area should be avoided. So in these cases, we're going to use alternate sites, and to identify safe alternate sites, we will be using anatomical landmarks. These landmarks are based on the bony structures of the rib cage and the pelvis. The The first anatomical landmark we should identify is the xiphoid process. Also, the costal margin at the midclavicular line. The ninth intercostal space is the location at the lower rib cage where it angles sharply posteriorly. And the anterior superior iliac spine is the most anterior projection of the iliac crest. Notice the iliac crest itself does extend more superiorly above the spine. So this is the spinous process that is most anterior on the iliac crest. The first alternate site we will discuss is in the midline below the xiphoid process, and it is commonly referred to as the Li Wang location. It is 3 to 4 centimeters below the xiphoid process in the midline. This location is designed to avoid the intestinal structures such as the colon and small intestine in the lower abdomen. It will be near the left lobe of the liver and the stomach, so care must still be taken when entering here, and the stomach should be decompressed with a nasogastric tube. Another potential obstacle here is that the falciform ligament generally involves most of the upper midline and creates greater preperitoneal fat, which is sometimes difficult to traverse and to allow easy entry to the peritoneal cavity. The midclavicular line at the edge of the costal margin helps us identify Palmer's point. This is a location 3 centimeters inferior to the costal margin at the midclavicular line. This is one of the most common alternate sites for primary entry into the abdomen in laparoscopy. This location also avoids the colon and small intestine, typically in the lower abdomen. It is away from the liver and the midline to avoid the falciform ligament. The stomach should also be decompressed to avoid injuring the stomach when entering in this location. The ninth intercostal space is easy to identify where the rib cage angles sharply posteriorly, and this location can be used because it is more lateral and can avoid adhesions even from a large operation through a midline laparotomy, where there will typically be few adhesions very laterally. This also avoids the intestinal structures because it will be lateral to them over top of the descending colon, which is retroperitoneal in this location, making it further away from the anterior-abdominal wall. And the anterior superior iliac spine is used to identify the Jane point. This is 2.5 centimeters medial to the anterior superior iliac spine and 10 centimeters superior. This will, in most patients, be a point roughly at the level of the umbilicus. And this location places your site of entry lateral to the superficial and deep epigastric vessels to avoid bleeding in the abdominal wall. So we have a number of sites to choose from when selecting an alternate site when the umbilicus is not available as a safe point of entry. So having chosen a safe site, we now want to choose a safe method for entry into the abdomen. Blind entry was the procedure of choice initially in laparoscopy. The entry was done commonly with sharp trocars, such as the reusable metal trocars seen here. Because of the possibility of accidental puncture or laceration, More advanced trocars were made where the sharp trocar was covered with a retractable spring-loaded tip, so that once it entered the peritoneum, the tip was covered by the retractable shield, helping to improve safety. But generally, it is accepted now that sharp trocars should be avoided because of their high incidence for accidental puncture or laceration. In a help to reduce risk, the Verres needle was introduced. The Verres needle was actually invented by a Hungarian internist named Jonas Verres, who used a blunt-tipped needle to enter the thoracic cavity while treating tuberculosis patients early in the 1900s. This initial technique was published in 1938. Since then, more modern spring-loaded needles have been developed where the tip of the needle is sharp but has a spring-loaded blunt portion that once the structures are penetrated with the sharp needle, the blunt tip will push away any internal abdominal tissues to prevent laceration or puncture. And these are now used for laparoscopy very routinely. The technique for inserting the Verres needle begins by making a skin incision. Here we see at the base of the umbilicus, but could be elsewhere in the abdomen, and then advancing the Verres needle up to the muscle fascia. The next step is for the surgeon to advance the needle through the fascia, at which point they will feel a pop and hear a click, indicating that they have penetrated the fascia into the preperitoneal space. Next, they will advance the needle through the peritoneum and again feel a pop and hear a click, letting them know they have entered the peritoneum. Here we will see a video of the procedure carried out, where the surgeon inserts the needle and feels the first pop and click. The second pop and click means they're in the peritoneal space. Gently aspirating will show that there is no enteric contents to suggest they're in the bowel, or blood to suggest they're in a vascular structure. And then the water drop will be left in the needle, and if it passes by gravity, it means the needle is most likely in the peritoneal space. Then they'll start the flow of carbon dioxide on low flow, and if appropriate low pressures are identified, then the flow on the carbon dioxide is advanced to full flow, and we can be assured we have safely entered the abdomen with the Verres needle. Obesity presents a unique problem to entry through the umbilicus. In a low BMI patient, a 90-degree entry into the abdomen through the umbilicus would create a path directly into the major vascular structures of the central abdomen, namely the aorta, vena cava, or iliac vessels. So instead, a 45-degree angle is used for entry with the Verres needle, so that the tip of the needle is instead pointing away from the major vascular structures and toward the pelvic structures such as the uterus, with less chance of injury. In obese patients, however, the redundancy of the abdominal pannus will often result in the umbilicus being lower than in the non-obese patient. So a 45-degree angle in this case would place the tip of the Verres needle possibly in the bladder. So instead, we will use a 90-degree angle of entry, which will be below the major vascular structures and be in a safe location, again aiming toward the pelvic structures rather than the major vessels. In instances where the Verres needle has not been able to be used and has failed on 2 different attempts, or for those surgeons who would like to have direct visualization during entry into the abdomen, an open cut down has been used. In this situation, a small incision is made at the site that is chosen, whether at the umbilicus or an alternate site, and dissection is made into the peritoneal cavity under direct visualization. Standard trocars can be used for this, in which case the incisions must be kept small so that the tissues will seal around the trocar sleeve, preventing the release of carbon dioxide. Hasson trocars have been developed for open entry, and they have a wide tapered addition to the cannula sleeve to help create a seal, preventing leakage of carbon dioxide. The technique is to first incise the skin in a careful manner to not penetrate too deeply and risk injury to underlying structures. Then standard surgical technique using sharp scissor dissection or blunt dissection to clear the muscle fascia and then divide the muscle fascia under direct visualization. Typically, stay sutures are placed on the muscle fascia to help with retraction and also to help hold the Hasson trocar flange in place. Then the peritoneum can be visualized and grasped and carefully incised under direct visualization, or in some cases it can be simply spread open bluntly, and the peritoneal cavity can be entered directly under direct visualization. Finally, the trocar is then inserted into the peritoneal cavity under direct visualization to know that it is in the appropriate position. And then the stay sutures can be used to hold that Hasson flange in place to create a seal to keep carbon dioxide from leaking during the operation. Blunt optical trocars are now available that allow for accomplishing some of the principles of safety discussed previously. One is avoiding sharp trocars, and the other is having direct vision while entering the peritoneal cavity. The tip of the blunt optical trocar, as you can see on magnified view, is blunt, conical in shape, and bladeless, and this allows for the tissues to be spread apart rather than cut directly. So muscle fibers will be separated bluntly, and even fibers of the fascia will be bluntly spread apart rather than sharp cutting. This also allows for the laparoscope to be inserted through the blunt optical trocar so that the surgeon can visualize out the clear conical tip to see tissues as they are being divided. That way, vessels in the abdominal wall can be visualized and then the direction of entry changed to avoid injuring the vessels. And also, once the peritoneal cavity is entered, intestines and other structures can be seen and again directed away from to avoid injury. The surgeon will look at the laparoscopic screen, visualizing the tissues out the tip of the trocar as they are traversed. So here we see the subcutaneous layer as the laparoscope and blunt optical trocar are inserted through the initial skin incision. With gentle pressure, we will pass through the subcutaneous tissue and see the anterior fascia come into view. We're over the rectus muscle here, so we'll have both anterior fascia and then muscle and then posterior fascia. And in the center of the field, we see the muscle coming into view. With continued pressure, the tip of the optical trocar passes through the muscle and up against the posterior fascia. With continued gentle pressure, we will then traverse the fascia. And then we'll be at the peritoneum, and continued gentle pressure will allow us to enter the peritoneal space under direct visualization. The surgeon first inserts the laparoscope into the optical trocar, making the skin incision at the appropriate site chosen for safe entry, and then inserting the tip of the trocar through the skin into the subcutaneous tissues. With a gentle twisting motion, these tissues are divided, and watching the center of the trocar, we can see scarpus fascia divided, and then the anterior muscle fascia. Again, gentle twisting with very little inward pressure prevents an uncontrolled, rapid puncture into the abdomen, and instead a safe and slow, careful entry is accomplished under direct visualization. As we get through the posterior fascia, we work more slowly and carefully with gentle twisting, and sometimes sideward motion can help stretch those fibers without having to apply inward pressure. Some trocars require withdrawing the seal cap so that carbon dioxide can flow around the trocar into the peritoneal space, allowing space to then push the trocar in the remainder of the way into the peritoneal cavity. And here we see the peritoneum fibers are bluntly divided with the tip, and then the seal is pulled back, allowing gas to flow into the peritoneal cavity, so there's space for the trocar to enter. Some trocars are designed to have carbon dioxide flow through the tip of the trocar, so the seal does not have to be pulled back to allow carbon dioxide to flow. Once the trocar is placed in the peritoneal cavity, inspection of the area immediately below the site of entry as well as the surrounding area ensures that safe entry has been accomplished, and secondary ports can be placed under direct visualization. Once we have chosen a safe site of entry and accomplished a safe method of entry, we then carry out final sweep at the end of the operation to again review and inspect the intra-abdominal space for any signs of injury. So these could include bile, spillage, which would suggest laceration or puncture of an intestinal structure, or blood in the peritoneal cavity, which could suggest a vascular injury. It is important to remember that injury will typically be directly under the site of entry of the primary trocar or secondary trocars. And since the patient positioning will often tilt the table in one direction or the other, the signs of injury can often be directed away from the site of dissection, so that during the operation the field of view will be away from the area that injury may occur. So it is important that we look under our ports of entry as well as around the remainder of the quadrants of the abdomen to look for signs of injury, such as blood that may suggest a vascular injury, or bile or other enteric contents that may suggest a visceral injury to the intestinal tract. Here in this cholecystectomy procedure, where the patient is in a head-up position, signs of injury will be taken into the lower abdomen, so we will inspect the areas under the ports as well as both lower quadrants, and then also inspect both upper quadrants for any signs of port entry injury or injury throughout the procedure. So with these recommendations, we are able to accomplish safe entry into the abdomen by practicing the STAR technique and choosing a safe site of entry, choosing a safe method of entry, and completing a final inspection, and in thus doing reduce the incidence of accidental abdominopelvic laceration and puncture.